Thank you, Shumabrotus, for such kind words. Um, yeah. So basically, this is what I'm going to talk about today is about the diagnosis and management of this particular condition known as Myxedema Coma. Now, before, how do we diagnose Myxedema Coma? Let us just get back to the case again. So what are the salient points in this case? What we can see here, this is a 70-year-old radioiodine-treated Graves' disease, and this radioiodine was given around 3 years ago. And this patient presented with a right basal pneumonia without tachypnea and a shallow breathing. Now, this is very important. Mark it. Number two, the patient presented with a bradycardia with the first degree AV block, and the heart rate was pretty low, 48 per minute. The patient had an altered sensorium and was disoriented. Fourth thing, patient was hypotensive. The blood pressure was 85 by 50. Fifth thing, the patient had hypothermia. The temperature was 35 degrees centigrade. The patient had dry, cold, and extremities. Patient also had a facial puffiness and dependent edema. Patient was a known hypertensive on telmisartan and hydrochlorothiazide. However, and the patient was also known dyslipidemia on rosuvastatin. However, none of these medicines could account for the bradycardia, which was seen here, because the patient was not on any beta blocker. So obviously, this bradycardia, which was happening in this patient, was unrelated to any antihypertensive. What is missing in the history is the history of the current medications for any thyroid or in recent thyroid function tests post-radioiodine. This patient obviously had a florid hypothyroidism, but unfortunately in the patient's history, and this is a very important part in dealing with the Myxedema Coma, or for that matter, any advanced hypothyroidism, the recent thyroid function test reports and what medications the patient is taking for the thyroid. Because this patient had a radioiodine ablation 3 years ago, and obviously we expect the patient to go hypothyroid. So if that is not there, we are missing a big thing. Now let us look at the reports here. So there are certain things which are very important, which points to the diagnosis. The free T4 is down and the TSH is elevated, 35. It's not necessary, let me correct that the TSH has to be more than 100 to make a diagnosis of Myxedema Coma. The TSH just has to be elevated. And what other things are there which are indirect evidences which are pointing to the Myxedema Coma? The patient has got an impaired GFR. The patient has got a raised creatine kinase. Random blood sugar is low and the sodium is low. So all these factors are, I should say, additional factors or additional presentations or additional investigations which can give some positive results in patients with Myxedema Coma. What else? As we can see here, the white cell count is raised, and also the patient has got respiratory acidosis, and the chest X-ray is showing a pneumonitis in the right lower lobe. Now, all these features point out to the possible precipitating etiology, in this case, the pneumonia. So with this background, what are the points in favor of the diagnosis? Before we go to discuss what are the points in favor of the diagnosis, let us look at what is the definition of a Myxedema Coma. The definition of Myxedema Coma is that it's a decompensated state of hypothyroidism resulting from severe and prolonged depletion of thyroid hormones, leading to altered mental status and other clinical features related to multi-organ dysfunction, which this patient obviously had. And let us have a look at them one by one. So this patient had the frank clinical features of a florid hypothyroidism, cold extremities, puffy skin, hypothermia, raised TSH, and at the same time, the patient had a suppressed free T4, raised CK, this is something which is again seen in lots of patients of hypothyroidism with Myxedema Coma, a reduced random blood glucose, and hyponatremia. These are all additional features of a Myxedema Coma, as we can tell. There was this history of radioiodine-treated Graves' disease with a lack of documented follow-up. Now, this group of patients who have had a radioiodine treatment done for a thyrotoxicosis in the past and subsequently did not have an adequate follow-up are most at risk to develop Myxedema Coma. Depressed sensorium and hypothermia was present despite the presence of pneumonia. If somebody gets a pneumonia, we expect the patient to run a bit of a temperature, but this patient was hypothermic. And obviously the patient was confused. Now, this is something which can again happen because of the Myxedema Coma or because of a profound sepsis. Okay. And we have got here a precipitating cause, that is pneumonia, with shallow breathing and respiratory acidosis. And this is presumably due to the ventilatory failure, due to the weakness of the muscles of respiration. This shallow breathing and respiratory acidosis is presumably because of that. because of hypoventilation due to the weakness of the muscles of respiration, due to uncorrected hypothyroidism. So altogether, the clinical and the biochemical features that we have seen here are actually pointing out towards the possible diagnosis of myxedema coma. Now, let us get into some of the basic facts and misconceptions regarding myxedema coma. First of all, the term is a misleading term. Most patients are obtunded, not comatose. This is something which is very important. Just because a patient is not comatose, you do not rule out this myxedema coma. The term was first used in 1953 in conjunction with 4 fatal cases of coma in a setting of myxedema, and this was published in BMJ in 1953. It is a rare condition. The incidence is about 0.22 per million per year, and altogether globally till date, just around 300 cases have been documented to be suffering from myxedema coma when they were admitted to the hospital. However, despite such a rarity, it's a potential life-threatening condition. Till 1990s, this was associated with a 60 to 80% mortality. The situation is somewhat better now. From 2000 onwards, studies suggest that the mortality has gone down to nearly 20 to 25% only during acute admission. But this is primarily because of a rapid diagnosis and a rapid institution of treatment. However, these patients have got a long-term adverse outcome. This was a study done from Dr. Datta and Dr. Vansal's team from PGI, where they showed this was a study just on 23 patients of myxedema coma who presented for follow-up. The 7-year mortality was 52.2%, which suggests that these patients are at risk of other macrovascular disorders, which can lead to an increased mortality. It occurs 80% in females, usually more than 60 years, and usually occur in winter months, more than 90% cases present in the winter months. In fact, the couple of myxedema coma that I've seen in my life, they're all in the United Kingdom and all presented in winter months when the outside temperature was down to maybe less than 10 degrees. So what about the basic pathophysiology of a myxedema coma? The commonest reason is discontinuation of a levothyroxine replacement following a I-131 radioablation or a total thyroidectomy. In other words, the main source of production of thyroid hormone in the body, that is the thyroid gland, is not working. And to add to it, some other factors, like as you can see on the panel on your right, on the box on your right hand side, these are the factors which can precipitate a myxedema coma. There is a pneumonia or a urosepsis, any sepsis for that matter, but these are the 2 commonest causes. Exposure to a cold environment, any cardiovascular event like a CVA, MI, or a heart failure, any traumatic surgery or surgery without preoperative stabilization of the thyroid status. So that means you take a patient for a surgery, but you do not know what the thyroid status is, and the patient ends up in a myxedema coma. Gastrointestinal hemorrhage could be a cause or could be an effect of a myxedema coma. CO2 retention, as I've discussed, happens primarily because of the weakness of the respiratory muscles, leading to a ventilatory failure. And there are certain drugs like the narcotics, anesthetic agents, diuretics, particularly the thiazide diuretics, lithium, amiodarone, sunitinib, phenytoin, beta blockers, and phenothiazines, just a list, are some of these drugs which, in the presence of an uncontrolled hypothyroidism, can lead to the development of myxedema coma. What exactly is the pathophysiological abnormality? It's an obligatory reduction in the intracellular T3. And this is something which contributes to the failure to maintain the metabolic homeostasis. And what are the consequences? The consequences we have divided into several groups, but these are the 3 primary consequences of this metabolic incompetence: the neurological, the cardiovascular, and the respiratory. What are the neurological abnormalities? What happens is there is a cerebral tissue hypothyroidism with decreased cerebral blood flow and hypoxia, along with hyponatremia, the cause of which is different, we'll discuss later on. But again, all this can contribute to the increased confusional state. So the patient presents with an altered sensorium or coma. With hallucinations, it can present, and this is something which is given this typical name, myxedema madness. The patient can present with hypothermia, as we have discussed, for all these reasons, because the temperature regulation gets severely affected. There's a cognitive impairment. The patient can present with dysarthria or orophageal dysphagia and sensory or motor neuropathy. Regarding the cardiovascular outcome, again, the same problem is there. So there is an absence or a reduction of myocardial tissue T3 levels. This leads to an accumulation of mucopolysaccharides and water in the system, contributing to the diastolic dysfunction and hypotension. And at the same time, there is a peripheral vasoconstriction which worsens the peripheral circulation, leading to further cold extremities. At the same time, because of this myocardial tissue hypothyroidism, there is what is known as a reduced cardiac inotropy. So there is a reduced heart rate and a reduced blood pressure. So the patient can present in a heart failure or in hypotension, and they have even been noted to present with a cardiogenic shock. And these are the patients who have got the worst prognosis. There could be a pericardial effusion, but more often than not, this pericardial effusion is not an acute phenomenon, but something which has been going on for quite a while. Some of the deadly consequences of myxedema coma or such a purely uncorrected hypothyroidism could be presence of arrhythmias like VT and torsades pointis, which can lead to ventricular fibrillation ultimately in the long run. But the more common presentation, the more common arrhythmia is a severe bradycardia with the sinoatrial or atrioventricular block. Regarding the respiratory abnormalities, again, there is an altered respiratory sensitivity of the respiratory center. And at the same time, there is a respiratory muscle dysfunction. This is primarily because, again, of the deficiency of the tissue T3. And this leads to what is known as a respiratory muscle dysfunction. This leads to the ventilatory failure. At the same time, there is a higher preponderance of cough and expectoration of sputum and accumulation of pleural tissue mucopolysaccharides. This leads to the risk of pleural effusion. And because of this dysarthria and oropharyngeal dysphagia, there is actually a risk of aspiration. So these patients, particularly in an obtunded state, run the risk of having an aspiration pneumonia. And this is something which also at the same time we have to understand that their basic immune response goes down. And there is, in general, in patients with poorly controlled hypothyroidism, therefore there is a higher preponderance of cough and expectoration. The other systems which get affected are the renal system. Basically, there is a reduced EGFR with renal perfusion, and there is a reduced free water clearance. This leads to fluid accumulation, which on one hand worsens the heart failure, and the other hand, it leads to a dilutional hyponatremia. The other endocrine effects are, for example, because of this hypotension, a raise in ADH. And sometimes, which is very important, often these patients, there is a coexistent hypoadrenalism, also an impaired gluconeogenesis, which happens because of the deficiency of the T3. This can contribute to a hypoglycemia. The gastrointestinal system can be affected. There can be reduced intestinal motility, reduced intestinal absorption and flatulence, and paralytic ileus. This is something which is very well known in myxedema coma. But let us not forget that these patients can have a gastrointestinal hemorrhage as a precipitating cause, or a gastrointestinal hemorrhage could be just one of the consequences. So what are the clinical features presenting myxedema coma that should make you feel alarmed? If a patient who has got a previous history of treatment of thyrotoxicosis, be it a surgery or a I-131 radioablation, presents with features like fatigue, weight gain, psychomotor changes like a confused state, depression, loss of visual perceptual skills, the commonest thing is the patient is unable to grab something like a pen or a paperweight and put them in the right place. Incoordination is this something very important, which is also present in a lot of these patients. There is a gross cold intolerance. The patient would feel chilly even without any significant reduction of the environmental temperature. Hoarseness of voice, progressive dyspnea, new onset pericardial pleural effusion, presence of macroglossia, dry skin and brittle nails, muscle cramps, worsened neuropathic symptoms, constipation, periorbital non-pitting edema, and last but not the least, presence of a goiter should make you suspicious that this patient has probably got an uncorrected hypothyroidism and is at a high risk of proceeding towards a myxedema coma. So what are the investigations of a suspected myxedema coma? So this table gives you actually a good evaluation of how you should approach such a patient. So depending upon whether it's a primary, secondary, or tertiary hypothyroidism, the initial evaluation is a free T4, T3, and TSH. Then we look for the precipitating causes. If you suspect it's an infection, good, get a complete hemogram done. UNE, there is urine electrolytes, that's sodium, potassium, and creatinine.
Whether you have a minute.
Sorry?
You have a minute and a half to complete.
Yeah, I'll just finish up as quickly as I just haven't got too many slides left. So the other things, I think it's pretty obvious how you go ahead. If the patient has got a cardiac event, you go for a cardiac enzyme echocardiogram and a neuroimaging if necessary. A 12-lead ECG if necessary, and also check for the NT-proBNP. If you're suspecting a metabolic abnormality, go for the plasma glucose, cortisol, and ACTH. And this is very, very important, as I mentioned, because an uncorrected hypoadrenalism may be present in a large number of patients. And if the patient is not improving, you have to repeat the UNE, the liver function test, check the arterial blood gases if you're suspecting respiratory failure, and reevaluate for a multi-organ sepsis. So what about the management and prognosis? I will not really take much time. This is essentially symptomatic. For a hypotension and shock, you give for a volume resuscitation with normal saline, IV glucocorticoids with refractory hypotension. For the heart failure, inotropic support. For the bradycardia, give atropine or give a continuous ECG monitoring for AV block and prolongation. For the respiratory, again, you give oxygen inhalation, blood gases, drainage of any pleural effusion, and intubation ventilation as necessary. For sepsis, obviously, the choice of the broad-spectrum antibiotics. Hyponatremia, you monitor the sodium closely. If sodium is less than 120, consider administration of 3% normal saline under close supervision. The thyroid hormone replacement, again, you have to distinguish between primary, secondary, and tertiary. For the sake of time, I'm not going into all these. But always remember to obtain a baseline cortisol levels and ACTH, particularly if the serum cortisol is less than 10. And if possible, now it's difficult, it's more easy said than done, a short synaptin test would be ideal when the patient is more stable. But to start with, start the patient on hydrocortisone 50 to 100 milligram IV 6 hourly and continue it at least for a period of 7 days, followed by levothyroxine replacement by NG tube in a dose of 4 microgram per kg. So it should be an initial bolus dose of 300 to 600 microgram, followed by a daily dose of 50 to 100 microgram. Again, the recommendations, the guidelines suggest starting on an IV route, but again, IV levothyroxine is not available in India. So we have to give the levothyroxine by the NG tube. We should go for a lesser dose if the patient has got an established coronary artery disease. Levothyroxine 3, that is triiodothyronine in a dose of 2.5 to 25 micrograms per day can be given along with levothyroxine. In fact, when I was working in UK, this was the first treatment that was given in a dose of around 20 microgram twice daily. But again, this has shown no significant survival benefit. What about the prognosis? The higher the GCS score, the lower the aperture 2 score, and the lower sequential organ failure assessment of the SOFA score, these patients are preferable. Unfavorable patients or unfavorable outcomes in elderly, patients with associated pneumonia, other forms of sepsis, upper GI bleed that carries a very adverse prognosis, presence of an uncorrected hypotension and bradycardia, use of invasive mechanical ventilation, unresolved hypothermia, history of sedative drug abuse, and a higher SOFA score. These all carry unfavorable prognosis. So the final take-home message is it's a rare presentation of neglected hypothyroidism that is often precipitated by sepsis or a macrovascular event or a GI hemorrhage. The outcome can vary depending upon the several comorbidities. And the patient should be educated in continuation of treatment with thyroid function.
Sujay, we have lost you.
He has already finished. So no issue.